everyone should probably want to have a healthy private practice in radiology because that private practice is what kind of is the bellwether and the metric for how your job gets paid and done, right? What makes academics pay you a certain amount is exclusively based on what they have to pay you to get you to come to work, right? Or the corporate job, right? If private practice doesn't exist and everybody's employed, then there's no longer a fraction of revenues they have to give you to make you happy. They'll pay you as low as they possibly can. So even if you don't want to work in private practice, you should want groups who are in private practice to succeed because that allows you to have leverage against your employer to give you a good job, to not make you read too many cases, to take too much call, to work too many nights, all that kind of stuff. And so you do want that to happen. And so what I worry about um, is over time, more people I think are moving towards an employment model for lifestyle reasons and because they don't have a choice or whatever. And if that continues to happen and private practices do suffer to recruit and they cannot be stable, then they will want to sell or they'll just fold over time, or people will become more employees. And over time, especially as we do get more technological tools that change how we practice, it's going to push everyone's job potentially into a job we don't want to have.
Hey everyone, and welcome to our episode of Clinically Correlate with Azfar and Vedant. Today I'm so excited to have Dr. Ben White as our guest. Dr. Ben White is a practicing neuroradiologist at American Radiology Associates in Dallas, Texas, and an associate program director at the Baylor University Medical Center. He obtained his medical degree from the University of Texas Medical School at San Antonio before completing a radiology residency and neuroradiology fellowship at UT Southwestern. Just as importantly, he's run a blog for the past 15 years, aptly titled benwhite.com, in which he's shared his thoughts on medicine, medical training, and radiology. Ben's blog is a key resource for thousands of medical students as they navigated and approached STEP exams. I personally have to say that, I started reading his blog in 2016, helped me navigate my preclinical years, definitely was a huge resource studying for STEP. And I remember vividly being like, how do I get the answers for the practice, 180 questions that, that's freely available. And your answers were like the best thing in the world. And now as radiology residents, your website is kind of our go-to kind of we have like our discussion of trying to figure out where radiology is going in the future. So Ben, you're a huge inspiration for us. And I think honestly, half the reason we wanted to start a podcast to begin with. And we're so excited to have you on the podcast. Thanks for coming on.
Man, thank you so much. That is very sweet. I'm glad it's been helpful all these years. Sometimes, when you're just typing in your room late at night, you're wondering like, is this going to hit or not? And it's always nice to hear that it hits.
I can
Thank you so
definitely say
much.
it hits. It hits, and it definitely creates a large discussion board among us. I really appreciate you having you on.
Of
So
course.
we'll go ahead with some questions. So I know you've been giving grand rounds on preparing trainees as they are transitioning to their first jobs as attendings. If you had to boil it down to your top 3 pieces of wisdom, what would those be?
So it's really hard. What I would say is the overarching reality is that many people will not stay in their first job when they finish training, and what you envision your life looking like and what your job will actually be like may not be the same. So I think one order of business is just realizing that you don't stop learning and growing when you finish training. It's kind of just the next step. And so you want to critically evaluate both who you are as you work and kind of what you want from your job and that kind of give and take to make sure that you are happy where you are and growing as a radiologist where you are and not just kind of hitting your peak at the end of 4 year, then saying I'm kind of done and then slowly burning out over time. So that's one thing is just be aware that the jobs aren't always what you want them to be, but you still need to grow and become the best person that you want to be. And so to be active in that process. I think related to that is the money question, which is a classic kind of white coat investor thing of living like a resident. But the bottom line is that you also need to be aware that the future is uncertain. And so while you don't want to put off, the all the milestones you need to put off in life, the house and the cars and the kids and the childcare and the hobbies, you want to live a good life. You also don't want to handicap yourself by growing into your income so fast that you are removing the optionality from your future. So a lot of people will get into a job, grow into their income really quickly, and they can't pull back. They can't change jobs. They can't, change the way they practice, and they're kind of forced into a pathway that may not be the one that was right for them. And then the third thing, this is off the cuff, but the third thing I think I would say is back to the uncertainty of the future. I think with the AI question and the corporatization of healthcare and everything, I think a lot of folks have gotten very cynical about medical practice, and for good reasons, right? There's a lot of reasons to be distrustful of healthcare and the big corporations. And when you're a resident, you kind of feel a lot of that trickling downhill, all the things that roll downhill that you don't want to roll downhill, they roll down on you. And so I think it's very easy to focus on metrics that are very measurable for a job quality and what you're looking for, how much you get paid, how many vacation weeks the RVUs generate. And those are all valid things to look at. They're really important. But I think with that, a lot of trainees discount the non-measurables with jobs that I think are extremely important. Number one being culture of the group you're joining. Like you don't want to feel like a cog that does not matter this early in your career when you first start out. And a lot of people pick jobs where they are optimizing for just metrics that they can count on a spreadsheet. They can say, here's my job. It's this many RVUs a day, this many weeks of vacation. Here's my W-2. Here's my bonus. And I think when you do that, you really miss out on a huge part of what makes a job good or bad. For me personally, what makes my job good is not those measurables. It's, do I like going to work? Do I like my residents I work with? Do I like the doctors I read for? All that kind of stuff. And that's not measurable, but it is extremely important. And that's my point number three.
I think all three very valid points. Like you said, I think the toughest thing with radiology is we have things that are measurable, and we get so used to using that as a metric for everything. And like even when we're pushing ourselves and learning, even to see if when you've learned something, are you able to apply it? Honestly, I feel like the easiest way is to just see how much volume can you read, because even if that's kind of the imperfect way to say, are you able to apply it? That's the only thing we have, because rare cases that have complex pathology that you're applying the things that you're studying for is just it's this tough like signal to noise ratio to really go by. And then it just leads into, like you said, number of studies, RVUs, and then vacation and money associated with it. And so that all that stuff isn't really published, right? Like it comes down to, I'm sure, like when people say what they're trying to find for a residency like program, everyone says it's about the culture, and like it's a very tough thing to like understand when you're on the outside, but then ultimately when you're in the side, like that is truly the answer. And it sounds like that's kind of the same thing from a job standpoint.
Absolutely. I always said on the website that the most important factor for determining residency was gestalt, right? It's like the how do you feel about it? And that doesn't change. And the problem is obviously for jobs and for residency, it's hard to know ahead of time when you're being sold something or whether it's really genuine and real, right? Everyone's going to say, we're great, we're a team, everyone loves, all the warm fuzzies are always going to be spoken out loud, right? That's just the reality of reality. So yeah, I think it is hard, but I do think it's kind of funny. I mean, when I was a resident, I remember when we talked about call shifts, right? People would talk about how many cases they read as a marker for both how good they were and how the night was, right? Like, oh, I read X number of cases, as if like that number could summarize with your skill set or even what happened to you that night as a person. It's a really bad metric. It's a useful metric, but it's not that good. And it's really funny how easily it is for us to like cogify ourselves when we say that, like, oh, this person's a fast reader. This person is good because he can crush a list. And it's like, to a certain extent, it's very helpful when you're on call so you don't fall behind. On the other hand, as a field, radiology has prioritized, in many cases, the ability to churn out a high volume of crappy work, right? Because you get paid the same for good and bad jobs, as long as they're not dangerous and making huge misses. To a certain extent, a lot of people would prefer that a radiologist read as many things as they can to generate as many RVUs as they can to make money for the practice that, usually owns the hospital or whatever. And so, to a certain extent, we are kind of always on that spectrum talking about, the volume as a proxy for like everything else, but it's really not enough of the story. And so I do know a lot of people who have taken jobs and they thought they were going to like it. and then they get to the job and you're like, you know what, this did not pan out the way I thought it would. The culture that I was promised isn't the culture I got. And sometimes it is more, measurable stuff like, oh, they garnished my vacation. The bonus was smaller than I thought it was going to be. That stuff happens too, sure. But at least for me, I think when I see people burn out, it's because the culture is really fallen out from where they were.
I guess, Ben, a follow-up question would be like, are there any ways to scope out culture either when we're interviewing or in the pre-interview stage when we're looking for our attending jobs?
I think there's no questions that work for that, unfortunately, because I think everyone knows the correct answer. It's like, I ask you, any of the interview questions people ask for residency, right? They're all nonsense. They're all gameable to a certain extent, like they really are. So I think if you're being practical, the only thing you can do is try to meet a bunch of people and see what they're like. And not like, oh, are they cool? But like, do they seem sad inside? Right? Like if they seem, brutal and miserable and tired and frustrated and they kind of bitch and moan, like it's a probably a bad sign. It happens to one person, it's just an N of one, right? But if you are able to get your face in front of multiple people and they kind of have the same narrative, that's really your best bet. And I would say I would take it kind of a holistic view on that and not be like, they answered my questions in certain ways. I think it's more about like, do they seem content in where they are? Because every job's going to have good and bad things. So my job's not perfect either, right? But on the whole, I'm happy there, right? So if you ask me, things that I don't like about it, I could give you answers. I'm not going to not tell you the downsides, but I'm still happy, right? So some places will tell you answers for everything that sound good. They don't seem happy. And to me, that is the red flag, right? It's not like, oh, people left or the salary is low or those numbers things they're all relevant. They're part of the calculus you have to use. But what the red flag to me is when people are not happy. And that I think nothing else but that matters. And their answer to the question doesn't matter. It's really just how they seem, which is why it's important to meet people in the group, not just like one person, not just a recruiter, but like as many as you can meet.
Gotcha.
So going to the point of culture, going to the point of, I guess, the corporatization of healthcare and radiology specifically, you've spoken a lot about the effect of private equity and kind of almost being like a commentator of where you think the field is going. So, if you had to summarize, where are we currently with PE in radiology? And, do you think that it's sustainable / is there a bubble for radiologist salary secondary to private equity firms?
So I think things have stabilized a fair bit in terms of the degree of consolidation in sales that have happened. There was a big wave of private equity buyouts, over the kind of 20 teens because of the very low interest rate environment where kind of borrowing money was basically free for companies. They were able to borrow a ton of cash, grow up very quickly, and buy lots of businesses. And because of the inflation and the interest rates that are currently in play right now, that's not possible anymore. The ability to kind of grow and borrow money like that has dried up, at least for right now. What we're instead seeing right now is that all the people who borrowed all that money now have to pay some of it back, and they don't have the ability to refinance those loans. And so we're seeing bankruptcies. So last year we had Envision went bankrupt, and then another company called Acumen, which is a big radiology company, went bankrupt. And then this year, currently, like Radiology Partners, who's the single biggest employer of radiologists in the country, is restructuring. It's not bankrupt, but they are dealing with their problems, would be the euphemism for that. And so I don't think we're going to see too much more consolidation on that level, at least not in the short term. I think it raises a question, though, is what's going to happen long term, which I personally don't know. I'm bad at making predictions, but some of these companies are more stable than others. And when things kind of go badly, like let's say Envision last year, they don't disappear. So Envision still exists. They still, in bankrupt, they're still around. What happens to that company? It's now in the hand of its creditors. So it's owned by the debt holders who gave money to Envision to grow itself. They now own the company, but it's still there. So is Envision able to now grow more because they have no debt because the debt holders now own it? Or did they kind of lose credibility because of that, right? No one really knows yet how these things will pan out. And so I think what really happens, again, kind of boils down to a certain extent of like, where do people want to work and where are they willing to work? If you see these issues in a industry or a company and you say, I don't want to work in that environment, I'm going to work somewhere else, then those companies fail faster and they fail more. If everyone, again, is a little bit more cynical and says, I'm just going to take the job that sounds good right now, then those companies can weather a lot of mismanagement. And so I don't think it's possible to know exactly where we're going to end up. I suspect in some markets we'll see some groups that were purchased fail, and then perhaps they'll be reformed under new leadership with brand new groups of private practices could thrive. But in general, there's been a lot of consolidation in radiology, and that's probably not going to unwind very much, if at all. And so, we're in a reality where a lot of doctors are employed by companies. It can be a corporate practice like, Envision. It could be a kind of hybrid private equity model where you're kind of an independent group, but you're mostly bought out by an industry like RP, or it could be working in academics, right? Which is also a model where we are increasingly corporate, right? Where the radiologist, generates money for the academic mission by being paid less than they otherwise would be paid. And so I do think what's interesting to me looking forward in the future is how we see changes with the radiologist shortage and the labor demands we have right now, the need for more productivity, the whole AI question or mid-levels, like how does that get folded in to this ownership model? Because how you deal with those crises and what your job looks like when you have complete control over it, let's say in private practice, and how it looks when you are an employee of another company, like most people are, is very, very different, right? The incentives for investing in AI product and what you do with your increased efficiency are very different if you are a labor cost for a company that they want to reduce and get a better ROI on versus you are making the money and doing the work yourself and you're trying to find your own perfect balance between efficiency and income, right? So very different questions. And so I don't know what happens with that. I think to a certain extent, what you end up finding out is that there's probably going to be a dominant model there, and it's going to trickle down to everybody else, whether or not we like it or not.
So, with the past 10 years of private equity being there, it has also correlated with physician, like radiology salaries increasing. Is that secondary to just we're reading more and we're generating more RVUs, or are they using that debt when they're creating their private equity companies to kind of not pay you, they pay you a premium on the RVUs that you're generating, and that is kind of
So
also
it's the former, yeah. So
former.
in general, so overall reimbursement pressure has gone down, via Medicare, but incomes have gone up for two reasons. One is people are reading more cases. That's absolutely true. There's the productivity of a radiologist has gone up a lot over the past 20 years. The other part of it is that because of the radiology shortage, especially the past few years, people have been able to negotiate stipends and things that from their hospitals to sweeten the pot to deal with that. So a lot of groups who cover a hospital are now getting paid more money for overnight coverage, more money for evenings, more money for IR, all these kinds of things. And so those sometimes get put into a big pot and spread out more. So it's a combination of doing more work and then getting some income support from your contracts. In general, the way that private equity companies work is they actually do take a big haircut on the group. So it's very common to see like a 30%, 35%, up to 40% cut in revenues go to the private equity owner, depending on the deal you have. And so you're actually getting paid less from that. What they can do, and sometimes do, is they can prop you up temporarily if they need to. So for example, let's say you are a company and you need a breast imager desperately because breast imaging is very lucrative and you don't want to not be able to provide that service and you can't recruit. In most groups, you're not going to pay somebody more than they generate in revenues because you can't lose money. Hospitals who need a surgeon do it all the time, right? If you're a neurosurgeon, you're not being paid because you provide great care, and you do great RVU production in your surgeries. You get paid because the hospital needs to have your skill set, and they're going to pay you what that skill set is worth to the hospital, not what you generate. It's not RVUs based. It's based on what the need is in the hospital in order to have their neuro ICU and their stroke care and everything else like that. So they can say, if you're a private company like that, we need to have the service line. We're just going to temporarily inflate this job to get someone recruited because we need to have that warm body. That does happen sometimes. That's relatively rare. That's more like for IR and breast imaging typically, but they do have that ability to do that. And occasionally they will run deficits to do that. But in general, you make less money in those groups than you do in private practice because of that haircut they take. It's just not consistent because there's a certain black box component to how they do their financials in the back end. But in general, they have capped and taken money away from radiologists for sure. There's very few situations where anyone has sold a practice like that it made more money because of like organic factors, right? So when you think about like a group will make money, right? But they have, costs, things like, back office support staff, billing costs, those things. And so when you sell to a company, they're doing that for you, right? So theoretically, if, they are so efficient that they're able to make their money off those efficiency gains, then you wouldn't lose any money. Doesn't really happen that way, but that's the offer they say. They'll say, we're not going to take much money, don't worry. You're going to be so much more efficient. We'll negotiate better contracts for you. So in the end, you won't lose money. That's generally speaking not true, but that has been the sales point. So in general, people do tend to make less. And if you go online on Facebook, you'll hear from a lot of, former, private equity radiologists who are very angry because they were in groups that sold and they were promised a certain amount of money. And, while there are some good stories out there, most of them are very frustrated that they made much less than they thought they were going to make, especially if they did not benefit from the actual sale, right? So if you were the legacy partner who got a big buyout, you're much happier in general than the person who was in the workup with an associate, didn't get the big buyout, but did get the consequence of the sale. Right? That rug pull has been a single-handed like destruction of culture, I think, nationwide in many groups, right? And I think it's really poisoned the well for residents too, because everyone's terrified. Like, why bother joining a group to become a partner if I'm not going to make partner in the end because they're going to sell the group? And when I was coming out in the late 2010s, that was a huge concern. And I had friends that had that happen to them. I think now it's probably not a meaningful concern. I don't think most groups are going to sell very much at this point. So I think if you are training and you're wondering, if our practice worth it, I don't want to join a group that's going to get sold. I think the selling is mostly done for now. So I really wouldn't worry about that currently. The workup tracks have shortened up a fair bit. They're compared to the way it used to be because people have had to get more competitive. And so in general, the odds of you joining a practice and then having a long workup and then having the rug pulled underneath from you is pretty low now.
So in general, like residents, would you say that we should still like we shouldn't bother entertaining questions that are relevant to like private equity buyout or sellouts, or we should just completely ignore those questions when we are interviewing for jobs?
I mean, I would still ask because I would want to know the pulse of the group you're talking to and how committed they are to being independent.
Right.
One issue, the wrinkle with all that too, is that you can still lose a contract, right? So the group has to be healthy. So you do kind of want to know if the group is healthy in that sense, because if they're in a market that's dominated by a firm, you can lose that contract to that other, and they can try to kind of do an aggressive takeover. And this has happened in some cities like in Indiana, it was the case a couple of years ago, where the local group was basically muscled out by, it was RP in this case. And they basically they took the contract and then said, okay, if you want to come work for us, you can. So instead of buying the group, which they would have done a few years ago, they would have bought the group. But instead, they took the contract and then offered them jobs instead. That way, they could basically buy the group without buying it. It didn't work out for them. The people in the group did not want to work for them. So it was a very complicated issue and didn't really pan out the way that I think the company that made the purchase had hoped. But that is a real thing. And so I do think it's not irrelevant. I just don't think that there are very many sales now compared to the way they were a few years ago. But there's still fresh money coming in, and there's still some smaller companies that are still kind of further away from their debt horizons that are probably still doing some purchases. But the wave of like every half a year is like another huge group falling is, I think, probably not happening. But I wouldn't ignore it. It's still an important piece of the pie, and a ton of radiologists are working for these companies. And so ultimately, every job is a unique job. You have to evaluate it on its own merits. I think it's not the correct interpretation to say that a private equity job is bad, private practice job is good, because they're really funding models, right? There are good and bad actors everywhere. Part of why you were able to get a foothold in the first place is because people in private practice were willing to sell out, right? So it's not like there was not, radiologists who were willing to do so in the beginning, because of course there were. And so I think it's all relevant. It kind of plays into the culture card to a certain extent too. But I think there's a greater issue of just with the shortage, how groups are able to handle that, how they're able to handle too much work, how they're able to handle the inequities of volume and production. There's a lot of issues that go into making a group healthy, and the issue of what to do about contracts, what to do about potential sales, all that is part of that overall question.
Gotcha.
So I have a follow-up question on that. So with at least private practice models or even with like academic centers, there's at least a more long-term horizon to the practice, the culture, radiologists, and the patients. With private equity, ultimately, from my understanding, these PE firms, when they have their fund, they're buying these companies through. That fund at most has like a 10-year lifespan. And then ultimately, there needs to be some sale component for those PE firms to kind of make their money. And so, from my understanding, it really is they get a multiple on EBITDA and or like effectively the revenue they're generating, the profit. And as you kind of hit different buckets of your EBITDA, you can command a greater multiple. But for say some of these larger private equity firms, if they've already saturated the market, like one, what would they do next? And then two, like who would they sell to if at the end of the day, like the majority of their contracts would be predominantly RVU based? And then you still have the downward pressures from an RVU system. So it's kind of like where would they go, especially if with diagnostic radiology, it's not like the physical land, it's not like a real estate asset necessarily compared to say other practices.
And ultimately, that's why, radiology and healthcare are not Toys R Us and Sears, is that these roll-ups don't make a lot of sense in a variety of ways because they are labor-based businesses that do not scale, right? You make money by doing the work. There's no free lunch there. So unless, again, one of these companies happens to invent an AI tool that completely changes the game, ultimately they really don't have any leverage to do that. And so what most of them have done in the short term is they try to grow really big, really fast, like you said, pump up the earnings really quickly to look better on paper. And they have this big roll-ups because people can't, buy individual companies very easily, right? It takes time to make a big behemoth organization. And so the idea is like, okay, I'm going to buy a bunch of small groups and roll them up together. Now I have one big company. It's easy to market now. I'm going to find a bigger buyer to dump it onto. What we've seen is that those dumps have not really happened. They've had really struggled to find buyers for the bigger roll up, which is a problem because that was kind of their exit strategy in many cases. And so, yeah, their growth is not fast enough earnings wise to justify their debt loads, and which is why we have had the bankruptcies. What people I think often fail to realize though is that they go bankrupt and they do a bad job and they're mismanaged, they still exist, right? And so every group that's sold out to a private equity company is still a group. They still have their own contracts. They're still full of radiologists. So if the parent entity fails in some way, it doesn't just all go back to zero the way like before it's sold. That can happen in some situations, depending on how exactly it all pans out. But ultimately, these changes have already kind of happened. And so it's quite possible that, if a company goes bankrupt and it's now owned by its debt holders, well, then guess what? The owner changes. They didn't sell it for a big multiple, but ultimately it got sold to the way it needed to get sold, and now the debt's gone, and now they're healthier again. And ironically, you could grow inappropriately, be in tons of debt, completely fail as a company, and end up just fine because now your debt holder owns the company with no debt. And so all that stuff is wiped away. And so yeah, people lose money, investors lose money, pension funds lose money. The radiologists are still bought ultimately. And so unless people, are in the situations, get fed up and leave and go create their own private practices, the fact that they're sold now has already happened and they've already kind of lost out on the independence. You have to recreate that from scratch essentially, which is not trivial to do. And I don't know, frankly, what the appetite is in radiology coast to coast to recreate independent practices again. But what I would say is that I think academics is great. Everything is totally fine, no matter what kind of job you want to have. What I would say is that everyone should probably want to have a healthy private practice in radiology, because that private practice is what kind of is the bellwether and the metric for how your job gets paid and done, right? What makes academics pay you a certain amount is exclusively based on what they have to pay you to get you to come to work, right? Or the corporate job, right? If private practice doesn't exist and everybody's employed, then there's no longer a fraction of revenues they have to give you to make you happy. They'll pay you as low as they possibly can. So even if you don't want to work in private practice, you should want groups who are in private practice to succeed, because that allows you to have leverage against your employer to give you a good job, to not make you read too many cases, to take too much call, to work too many nights, all that kind of stuff. And so you do want that to happen. And so what I worry about is over time, more people I think are moving towards an employment model for lifestyle reasons and because they don't have a choice or whatever. And if that continues to happen and private practices do suffer to recruit and they cannot be stable, then they will want to sell or they'll just fold over time, or people will become more employees. And over time, especially as we do get more technological tools that change how we practice, it's going to push everyone's job potentially into a job we don't want to have.
This is a great point. I think, what I feel personally is that, there's the good and bad with the RVU system, but especially at least with the RVU system, there's you can know what the overall government effectively and then the insurance companies are valuing the work that you're doing. And especially with diagnostic radiology, it's effectively like 100% of a service fee that you're getting with very minimal overhead, which is kind of rare compared to any other job. And like you said, there, like when you know how much you should be paid, even as long as that's being set by the market, in this case private practice, it at least like you're not getting a huge discount compared to if you're going to like a PE firm or academics versus people say in tech or finance, they're managing a much larger business and maybe taking a very small percentage of that as their own salary. So the actual tie between the work that you're generating and the ability to take that home from a service fee is a pretty high thing that's kind of rare, I think, in medicine, which has its pluses and minuses, especially as you can just commoditize that and that kind of erodes the culture, like you said before. I think we can talk about this for a long time. We have a bunch of other questions, so we want to pick your brain on. So I think we'll move on to the next topic.
Yeah. I think, we'll tap into one of your other expertise, which is, serving on the leadership of your residency program. A couple of interesting questions that we kind of came up with is, all of us go through an intern year, and there are differences in opinion, whether it's helpful, whether it's not. What do you think, as a program director, assistant program director, do you think that the intern year has been helpful, or do you think sort of instead of having an intern year, we could do like an integrated clinical experience where we, get into clinical services throughout the residency program, or, we tap into other sort of experiences that are relevant to being a radiologist, such as, I guess, getting more sonography experience?
I think that question gets to the crux of like every discussion about medical training from medical school and pre-med all the way through, which is that we always ask the question like, oh, why do we do thing X? Is it helpful? Like organic chemistry, physics, intern year. And the answer is always, people say we shouldn't do it. People respond, that thing is the best thing about why I do what I do. And there's always this like very precious viewpoint on it. What I would say is that these things are all helpful. The question becomes truly is it helpful enough? It's not, is there any value in it? Does the value justify the time and energy invested in it? So intern year was valuable to me. Sure. I'm not going to say it wasn't. Am I better in some ways in what I do because of that? Sure. But would I have been better served by something else? Quite possibly, right? I think that's a very reasonable way to look at it. So would it have been more meaningful to do, random months of clinical work throughout residency? Perhaps. Would it have been more reasonable to do several years of radiology and then park yourself in the clinical department and field questions and go on rounds with them so you could really see how the clinical care was impacted by radiology when you actually knew radiology? Sure. Hands-on clinical training for ultrasound. Gosh, people could really use that, right? So there's a lot of things that would be potentially equally valuable, more valuable. I think the problem is in a lot of medicine stuff is that we are almost allergic to change in general. We don't like to change things, but also it's all about what's convenient for the system we work in, right? So you being bouncing back and forth for clinical services is very inefficient for the residency. They don't really want that. They want to have you predictably here on service, covering the bases, manning the phones, all that stuff. And because of that, nobody wants things to change, right? Like, why did the ACGME ever say that we have a competency-based curriculum with the core competencies now, but then pretend that time-based education is a valid approach, right? So we say you should be able to do X, Y, and Z during these years, during this rotation. But if you can do X, Y, and Z faster, you can't graduate earlier, right? And the fact of the matter is, it's bullshit, right? It's nonsense that we would ever do it this way. I don't care how long you've been a trainee for. I care how good you are. The idea we had this kind of proxy value where we say, this person's training is long, therefore it's good. This person went to program X, therefore they're good. It's all a lie. It's all a lie. There are residents that are ready to be independent radiologists within like during second year because they're just so good. And there are residents that should never be independent radiologists because they're so bad, right? And then we have the whole spectrum coast to coast. That's just the reality of stuff. And so back to your question of the intern year, it's valuable. I don't think it probably is valuable enough to honestly justify, especially given how long training is, how radiology has changed. I would like to see streamlining it in general. I think given the reality of radiology practice, you know, it's really hard to justify both a year of fellowship and a year of internship in this process when most of us really, when the field has overall moved towards people doing fewer, not more things in their careers. It's a little bit of an inefficiency there that I think is hard to justify, and there's a lot of costs to it.
Yeah, yeah, absolutely. I think personally, for me, if when I look at my fourth year of medical school and my intern year, uh, if you asked me if I could give those up, to gain back that time, me having, an infant going into toddler at home, I would say absolutely, because that
Exactly.
time is super precious. Having that attending income and kind of being in a practice environment without, where I'm not working as hard as a resident per se, would have been valuable. Kind of moving along, the question chain on education, we're or the ABR is bringing back oral boards now. Do you think oral boards is going to lead to better radiologists?
I will posit that it's possible it will have a positive impact. And the reason I say that is because I don't think the oral boards themselves are useful. I think they're probably not. But I think how you study during residency will change because of them in a way that probably will be helpful. So when I was a resident, we had just moved from, we were actually in the process. I was an R1 the first year the core exam was offered. So I got to see the residents who were going to take oral boards and then the residents who were exclusively, core exam based. And there was a loss of a certain skill set, the ability to speak cogently about radiology findings in a, polished, appropriate, quick way. Is that skill set valuable? Absolutely. So if people can gain that back faster during residency, so that they are kind of more confident and helpful and get to the point more and not just relying on the power scribe, editing to make sense of what their thoughts are, that's valuable. That being said, I don't think any of that's the right way to do boards, probably, but I do think it's a real thing. So I think, when people pass or fail the boards, is that going to be meaningful in terms of are they, is it going to be a barrier to graduation for bad radiologists? Probably not. I don't think that's probably going to be true. But I do think people taking that ability seriously will be helpful. I think we moved away from those kind of hot seat case conferences. And practically speaking, that's an important skill. People do come into the room, want rep reads. Is it fair? Maybe not. But being able to handle that probably is valid. Judging you based on that for a test, I'm not really sure is very valid, frankly. But in terms of the training you'll get and you'll put yourself through, that will have some merit for sure. I think so.
And I think to me, it kind of brings you back to, I mean, we were fortunate enough. I don't know if Vedant took it, but I didn't take Step to CS. And I was fortunate enough to be in that group when Step to CS was canceled. And I think they had similar thought process, right? Can we interact with the patient in a standardized, can we standardize that process itself? Can we actually quote unquote doctor, right? And once to scrap that, then they kind of pushed a requirement to medical schools, like, they should have their own process set up so that, their training physicians were competent in interacting with patients, right? But again, I personally didn't think, just going through when I was preparing for Step to CS, right? It was all about preparing for the test, not necessarily what is best for the patient. Can I collect all the relevant information that I know will be graded, will be on the grading scheme quickly? I didn't care about accuracy. Right? When I'm listening to the lungs, I will just like 6 points, boom, 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 boom. I don't care what the lungs sound like, whereas in the real clinic, right, I would have a much, much more different approach. I knew I needed to fake the empathy during these Step to CS, but in real life scenario, it was very, very different, right? I think you're absolutely right that, if it should inspire that sort of preparation where, residents and fellows can succinctly describe cases to ordering or consulting physicians. But as you said, I'm not sure if it I'm not sure if we'll get to the point where we'll start kind of gamifying or preparing for the test, specifically for the test, rather than what the test should inspire.
It'll be both. I mean, people definitely will get the skill set. I think you are correct, though. There's always what we call casemanship, which is a kind of gamesmanship, right? There's definitely a performance art to it that I think is kind of nonsense, frankly. I always thought it was very irritating when I was a junior resident and be like, "Can we just do the case, please, guys?" Like you have to do the whole performance part of it.
Right.
It's funny to me because it's like ultimately these are all kind of like proxy metrics for like what we really want, which is I want radiologists who are good at doing radiology. Does the core exam do that? Does it help me distinguish between good radiologists and bad radiologists? The answer is obviously not. We all know it doesn't. Will the oral boards do that? I suspect still probably not, honestly, but it may be a step in the right direction to a certain extent. And the fact of the matter is, the certifying exam under its current iteration makes no sense. It's really the same thing as a core exam, and they could not justify that forever because it really has zero value add, and it's just basically unfair to even demand it. But they don't want to walk back having a certifying exam. That's very embarrassing for them, and they really can't do it. I think emotionally, they don't have the ability. There's a whole sunk cost and identity wrapped up in that. And so for them, they had to change the exam. And this is how they decided to change it because it probably is the most familiar to them. It's the easiest lift to do. And doing something more creative, like creating a real simulation-based exam, which I think I've always advocated is the right way to do it. No one agrees with me, it's fine. But that would be a big, heavy lift for them to do, and they don't want to do it. So we're going to go to oral boards and see how it goes.
So if the number of cases that you read is not a good metric, if the way you take cases is not a good metric, if like the multiple choice questions you do is not a good metric, as your position as a program director, what are good metrics to evaluate residents?
If they're right when they work, right? Like see overnight work, am I addending it or am I not addending it? Are you right or not right? And in your reports, are you clear? Right. So I had my very first attending in radiology when I was an R1 had a saying. He would ask a question when you first started on the rotation. He said, "What is the purpose of the radiology report?" And everyone would answer things like, "Oh, to find disease, to get the usual answers." And he would say, "Wrong," like Conan the Barbarian style, like wrong. He would say, "The purpose of the report is to create the right frame of mind on the reader, right frame of mind. So they should read your report and come away with what you want them to think. There should be no breakdown there." And so being good at this job, to me, in general, the most important thing about it is when you make a report, is it correct? Is it accurate? And is it clear? And if it's accurate and correct and clear, it's a good report and you're a good resident. Obviously, there's more to it, right? Are you professional? Are you on time? Are you good to your patients? Do you answer questions? How do you interact with your teammates and your techs? Those things are for the residents to do, right? That's what residencies are for, is to evaluate that stuff. But as a board making tests, what am I interested in that perspective? It's that. Are you able to do the job of radiology? Are you able to look at a stack of images and make reports that are accurate and in a reasonable time frame, right? The residencies themselves have the other part, which is, are you hardworking and pleasant and all that stuff like that, which is super important. But I don't think the oral boards will help us figure that out either, right? Like, I don't think I'm looking for the ABR to tell me if my residents are good people or not. I can figure that out myself, I think.
That's fair. I mean, it's a simple answer. Just be right. And I think like to all those different aspects of training and evaluation, it doesn't get to the point of the actual practice of radiology. We have access to our macros. We have access to Radiopedia, Radiology Assistant, and honestly, we probably interface with our adjunct knowledge tools in real time faster or just as fast as a lot of different people. And so, I remember just being an like pre-med student being like, I shouldn't have to memorize biochem stuff. Said that as well when I was a medical student. And unfortunately, you get trained that you have to because that's what the system demands. But then when you're actually practicing, especially when you have a computer in front of you at all times, there are some things that you don't, and it's just easier to offload that and then look it up as needed when you need to. So I think that, like you said, like, are you able to just generate right reports independently as the best kind of marker of a good resident? It's that hidden kind of curriculum as well that I think it's tough to train. I don't even think we've talked about it like as co-residents, but I
It's
think
even the idea also of how much are you on the, the area of the curve for being sensitive or specific, right? Where it's, so much of the testing is about like differentials, which are again things you can look up. What you really want to do is how is your eye? How's your attention to detail? When you make a finding, can you make the ancillary findings, satisfaction of search, like how cognitive biases of being a human being, right? That's all things that I really want to know. And that is just not part of any test in any medical school format we have, right? We have longevity. Like, do you have stamina to get through a long test? That's as close as we come. Is like if you were, at some point you have stamina, we catch you on that. But I'm more interested in those other factors, which are very hard to get to. And I can tell my residents what they have, and we talk about it. And I know, and I share with them my examples and my failures because I'm also a fallible human being who makes tons of errors too, right? But I think that's where it boils down to. And I think that conversation is very much missing. Even in residency during Readout, a lot of programs, it's very much like performance punitive stuff or it's scribing. There's oftentimes not that back and forth of like a real, genuine connection and conversation about why we're all here, what we're all doing, how we can get better every day, deliberate practice. Like it's really just not how we talk about it. We really like are not doing that on a daily basis, and we don't do it in our testing either.
yeah, 100%. And to the point of like training your eye, I think after your first year, you don't really do side-by-side readouts to see exactly how the attending is even approaching the images. And that's something as like a second year resident now, especially after I've been on nights and I'm like, oh, these are some of the mistakes I've made. How do I actually correct that? I've only been able to correct that, not by like being like, oh, I missed that finding, but kind of observing very intentionally, seeing on day rotations what the attending is doing that's must be different from me and something I didn't know to pick up on as a first year resident, which is a whole lot. But like it's that level of improvement from an eye test standpoint that again, it's definitely hard to test and definitely I think really hard to train as well as we progress from the initial stages.
There's a whole like layer of the onion component to learning where what you're able to pick off from your attendings stuff is different when you're in R1 versus an R2 and so on. And I always try to give people my process and kind of vocalize what I'm doing when I read out. What I also personally do in my practice is that I never have a resident edit their own report, basically ever. When I get a report from a resident, I have them sit next to me and we edit it together so they can see me look at the images without having to take notes. I don't want them with their looking down at their paper. I don't need them to write down, moderate right foraminal stenosis 5-6. I don't care about that. Like I want to see why I'm calling things what I'm calling it and focusing on my approach and the pitfalls that we can avoid and where they miss something that I find something, how it is that I found it when they missed it, right? 'Cause like you said, that's how you learn. Seeing the changes is part of it, and that's how you learn overnight. And that's a big part of it too, is being wrong, waiting a while, and then being like, oh yeah, I get it now. That's part of it too. But part of it is this other part that I think when I was a resident, I used to get a lot of, writing my notes down kind of stuff. And it was like, I'm not learning anything right now because I have to go back and try to figure out what was really happening. And that disconnect, like already like opportunity was lost, right there. So that's how I do it. And I personally like it that way. But it's very hard. I think the residents do miss out on a lot of that opportunity if they don't have that because it is different to approach it as a novice and as a seasoned learner and then as a quote unquote expert at some point. And I still have alterations to my search pattern that I'm developing over time because of my own misses, my own, pitfalls in my knowledge base, my own pitfalls in my approach.
Yeah, 100%. And I think what you felt as a resident is definitely a universal feeling among us as residents still. And so, I think it's very much appreciated when attendings kind of take their own feedback or what they felt that should have changed and then actually change it when they're in that position. So I appreciate that. In the interest of time, we have about 5 to 7 minutes left. So just a few last kind of hot topic stuff that we want to talk about. So as far
and I'm really interested in the first question, the hot topic question. One of the things our chairman mentioned, Mitch Snall, was as treatments get better and better, all of these previously fatal diseases are transitioning to chronic diseases, right? Classic example, or like a classic group of diseases are cancers, most cancers, right? And so one of the things he mentioned was that every time these cancer patients get admitted to the hospital, the cost of their care is astronomical, and they frequently get admitted because maybe their disease is progressing, they come down with more and more acute symptoms. And so one of the ideas that has been floated around is using imaging as a screening tool for not just for lung cancer or the ones that we have, but more broadly, right? Kind of as a baseline for our imaging. Any thoughts on that, especially now we have companies that are offering full body MRIs commercially?
It's funny. I think most people in the radiology community have been very negative on like Prenuvo, for example, for the whole body screening. And they're probably not wrong to be negative right now. I think the screening question is very complicated because part of it has to do with what happens when you make the findings, right? So envision a world like several years from now where you could provide a whole body scan for a couple $100, cost of mammogram or something like that, right? And then most things, we had enough data at that point to know which things you could follow versus which things required a more invasive test of some kind, right? Because the harm comes from overtreatment and over-invasive tests. So the biopsies, and the things like that, androgens that get clipped that shouldn't get clipped, that kind of stuff like that, right? So if you could provide a low cost, high quality screening where the only downside was more screening, but screening was not expensive, and everyone just got a $200 test every year, that'd probably be fine, right? That probably would not be a bad thing. The problem is right now is that we don't have that ability. The screening is very expensive. It's very, very expensive. And basically, once you pay for it, the answer is always come back for more screening. And then if you find anything, the answer to that is typically either more screening, faster screening, or something very dangerous. So you have to be in the perfect spot of a disease for it to help you, right? If it's too far gone, it didn't help you, right? If it's too early, it won't help you. If you're going to catch turtles versus the whole analogy there is like, a turtle's so slow you're going to catch it no matter what, right? So you don't need a screener for it. And then the hare is so fast you can't catch it. It's going to come up no matter what, right? So you want the perfect aggressiveness of disease to catch with a screening modality to actually help out. And there's no intuitive way to do this. You have to look at like huge data to know if you're helping or not. And I think it's one of those ironic things where I know right now, chances are the data is not supportive of this kind of stuff. But I think you ask people individually, you kind of want to know? People are like, yeah, I kind of want to know. Like, it's very hard, I think, as an individual to weigh risk and reward, and as a population to do it. And so I think the bottom line is that there's a world where that makes sense. We are probably not in it right now. I don't know how you get from the current world where it probably is a bad thing to the world where it is a good thing. And it may just be a matter of, more blood tests, lower cost, and better data. But certainly the $2,000, bespoke blood test MRI extravaganza for the worried well in Silicon Valley probably is not the right way to do it. But we live in a capitalist society, and that's how it's going to happen for now.
Absolutely. And I'm kind of in the bucket of I want to know, and I want to know early, right? Especially because as I'm training as a radiologist, I kind of know what to do with the information, regardless of what the interpreting radiologist makes. I know to go to ACR, look at the guidelines, see what they say, and kind of look up my own, do my own good research on PubMed or other credible resources, and kind of go from there. But then I have the advantage of being a clinician, a physician, a radiologist, right? But I understand a lot of the general public,
because like you'll have money, so you can afford it. Like, so
right.
realize pancreatic cyst MRIs, right? Like if you got put in that pipeline, the IPMN pipeline, where you're going to get a pancreatic cyst protocol every year forever, that's not going to bankrupt you.
Right.
But if you were stretching to pay for that Prenuvo exam and then you got put into the pancreatic cyst pipeline forever, man, that's a big cost to your life for all time that you just signed up for because you have a pancreatic cyst. And so I do think it's one of those things too, where it's like, you could deal with the consequences of that, both cost and emotionally, probably more than most people can. I wonder at people who are going to be in situations where they either don't have the psychology for it, the support for it, or the money to deal with the consequences for things that they did not need to have screening for. It's like even like breast imaging is obviously very, very accepted. People are still fighting about it, about what the right screening date is, how much of it is lead time bias. Like it's been going on for decades. We still can't decide about the most popular and most beneficial screening modality we have. Like how are we going to, if we can't get that figured out properly and universally is accepted, we are, I think, a very long way away from knowing about whole body MRI screening. But your point is taken. I mean, and I get it too. I get the desire for knowledge. It is we're in the knowledge business. Like that's what we do. It's hard to be like, I do it every day, but I don't want it for myself. It's hard. It is kind of hard. I agree with
Yeah.
you.
Yeah. And especially, being at a tertiary care center, we end up seeing lots of young patients with very advanced presentation of diseases.
Yeah.
I think that is also coloring, like biasing my vision as well. Yeah, you could say it's 0.1% chance. What are the odds? And you end up seeing like 4 of those in a day, and it
Yes.
kind of internally freak out.
Oh, I'm terrified of brain cancer, right? I read brain cancer scans every day. Like I have a disproportionate fear of that kind of cancer more than other kinds of cancer. And it's only because I see it all the time. Why would that? I'm more likely to get a different kind of cancer than that one. But if you ask me what I'm scared of, it's like GBM, 100%. Like that is what I'm terrified of. Can't help it.
So, Ben, we have one more question, but I actually don't want to get into it because it's the hot topic of AI and the dilemma of volume, which I think could probably be a whole other discussion just by itself. So, just if you want, you can, kind of short answer, yes, no. Do you think implementation of AI is going to lead to an overall better approach and a better practice of radiology? Or do you think all it is just going to lead to efficiency gains and then ultimately whoever owns the practices benefits from that?
I would like to think that we would have the right balance, right? Because if you were twice as productive, you could either read the same amount of time, read the same amount of cases, and have a much easier job, or you could 2x your productivity and have the same job, or find some balance of, a good longevity career where you are doing a right amount of work. The problem is, the ROI for these investments that people are making decisions about is basically based on money. And so, yeah, if you are an owner of a company, there's really only incentives to do what you need to do, kind of health wise, to keep people employed. Otherwise, you do want to maximize productivity. And so, in a private practice, I personally don't want to work harder. And if I could read faster, I wouldn't want to read, up to that maximum thing. I want to have an easier job, I think, to a certain extent. But how do we control that? And then to a certain extent, over time, because people are employed so often, if one big actor takes that model where they are just eating things up because they're so efficient, how does that not trickle down to other folks? I think it's very hard for it not to. So I don't know how it's going to pan out. And the funny thing is too, is that there could be a golden age where people were able to be more efficient and make a lot more money very, very temporarily, right? But then once people realize that you can read twice as many cases in the same amount of time, it's going to be raced to the bottom again. And so even people who are chasing that idea is self-defeating over time because all it's going to do is just eventually catch up to where everyone is clicking away like crazy. And so I think it kind of just ends up boiling down to the societal question of how do we handle this as a world? Because radiology is going to be one example, but it's not the only one. How do we value human work in the future? And that question, I think, is very much up in the air. So I don't know. Uh, I'm optimistic in the short term, let's put it that way, but I'm not sure about the long term.
That's fair. Yeah, I think like you said, it's a how do we handle human work in general across the board, not just in radiology, in medicine, but pretty much everything possible right now as technology does get better and different skill sets are necessary as we move forward. Ben, this was an outstanding podcast episode. Thank you so much. I have to say, you're just as eloquent when you speak as for the past 15 years. So this is amazing.
Oh man, thank you for saying that.
No, you
All right.
definitely learned a lot in the past hour about all, aspects surrounding radiology. And it was definitely like, a great episode and just a great learning session.
Thank you guys. It's been a pleasure.
Thank you so much. We'd love to have you back whenever you're available to talk about the next thing that you're passionate.
Round two.
That's good.
Yeah.